Good afternoon, everyone, and welcome to Black Health Trust, today's edition. We are going to have another stimulating conversation. Today, we're going to be talking about how coronavirus is infecting more people and how we can create strategies to be safe and to stay safe. And to help us in this discussion today, we're welcoming back a speaker that has been with us on several occasions, and we're really excited that he could take some time out of his busy day and join us. And that would be Dr. Jerry P. Abraham, the head of the Kedron Health Center there in LA. And with that, I will turn it over to our founder, Dr. Randall Maxey.
Good afternoon, Dr. Neighbor-Stevens, Dr. Walks, Dr. Abraham, and all of our honored guests and advisors. Thank you so much for joining us. And Dr. Jerry Abraham has more energy than anybody I know, so I'm sure this will be exciting. And I'm claiming him as my personal COVID physician advisor as I navigate the cities and the practice that I do. To start off this discussion, I'm going to just review a few slides to get Dr. Abraham riled up. It didn't take much. So approximately 25 million kids worldwide this year have missed routine vaccinations, the diphtheria, tetanus, pertussis, and I understand that the infections of measles have gone up as much as 80%. Next slide. And a lot of this is due to not only the misinformation that's been hawked about COVID-19 vaccines. So we know that the Centers for Disease Control found that in January, during the height of the Omicron wave, an unvaccinated person was 12 times more likely to be hospitalized than a boosted individual, than a non-boosted individual. And that's a completely different discussion when you talk about the relative risk of somebody who's not vaccinated versus somebody who's quadruply vaccinated and being around other people. That's the message that doesn't seem to get through to a lot of people, that these vaccines are truly highly effective and prevent hospitalization and death. They don't necessarily prevent you getting sick with the virus, but they mitigate against the severity of it. Next slide. So we know that this week our president, Joe Biden, tested positive, but he's double vaccinated, double boosted, and is having only mild symptoms. And he is also receiving the Paxlovid pill. And we know that this is highly effective in keeping people out of the hospital. Next slide. So Paxlovid, and Dr. Abraham will mention that, but this does reduce hospitalizations and death by 89% in high-risk patients. So that's something pretty good. And we understand there may be a little controversy about relapsing, but it may be that the medication has not been prescribed for long enough. Some people have questioned the 5-day course versus one that's longer. Next slide. So we know that the previous president, Trump, was not vaccinated. So when he went in the hospital at Walter Reed, he was given a monoclonal antibody that was made by Regeneron, as well as something called remdesivir, which is an antiviral. But we know now that this BA5 is an escape artist, and we don't know what's going to happen with all of these viruses and variants being able to escape current treatments. Next slide. You want to go to the next one? Is that the last one?
Yes.
Okay, let's turn it off then. So, Dr. Jerry Abraham, who's turned out to be a good friend and a good resource. He is an MD. He is a Master of Public Health and a CMQ. He's the Director and Chief Vaccinologist at Kedron Vaccines. He's a family and community medicine physician, a global injury epidemiologist, and a medical quality specialist. He's a trustee of the California Medical Association, which is CMA, which is the AMA, the American Medical Association. He's the president of the Los Angeles County Medical Association, which is known as LACMA. He's a counselor in the American Medical Association. And we welcome and honor Dr. Jerry Abraham. Welcome, doctor, and thank you for sticking me in my shoulder this week so I can go to Atlanta to the NMA.
Yes, excited. Want you to travel safely. Thank you so much for having me, Dr. Maxey. It's a pleasure to see you again, Dr. Nagreet Stevens and Dr. Walks and all of our friends and family here on a Sunday as we continue to, put one step in front of the other and march along and really try to close the chapter on the devastation of COVID and look to the future. And so that's really what I hope this talk is about today, is just really what we continue to do to stay safe, be safe, and really, keep the right things on our radar, equip ourselves with the right tools and knowledge, so that way you can make all the right decisions, informed decisions for you and your loved ones, your family. And that's really important at this time, that you have that information.
Can we get your volume fixed just a little bit?
Yes. Are you having a tough time hearing me now?
We can hear you, but maybe it could be a little bit louder. What do you think, Dr. Neighbor?
It sort of sounds like an echo chamber, kind of like you're far away.
Is that any better? Still the same.
I thought it was a little better.
Give me
Okay.
1 second. Let me see if I can change up the microphone.
Okay.
In the meantime, welcome, Dr. Walks. How you doing, man?
I'm doing well, Dr. Maxey. Always good on a Sunday afternoon. Church in the morning, Black Health Trust in the afternoon. Always good.
Okay. Amen.
Let's see. Does that work any better?
Yes.
I think that's better, yes.
Okay. All right. Let's see. So as I was just mentioning in the introduction, our goal here today is just to really make sure you have all the information you need, and that we know where we're at and where we're going when it comes to the COVID-19 pandemic. I did want to start with just a few moments on monkeypox, given that that's on so many people's minds. So just really briefly, just want people to know, you're hearing a lot about it in the media, you're seeing it in the news and on the newspaper. And yes, there are cases spreading throughout the United States, and you may have seen that the World Health Organization declared it a public health emergency just yesterday. So we do want to keep that on our radar, but just know right now it's a self-resolving illness that really doesn't cause death, and we have seen very few hospitalizations, only for the pain that the actual lesions, they're these maculopapular rashes can cause some painful little bumps. And so for those, sometimes people go to the hospital to get some pain medicines, but otherwise they do resolve, whether it's in 1, 2, or 3 weeks. But during that time you have those bumps, that's when people are very infectious. So we want to be very careful of that, and it's spread by skin to skin contact. So that's why we're seeing it in groups that may touch or hug or kiss a lot. And those are some of the issues that we've seen. It's really been restricted at this time within groups, particularly men who have sex with men in certain circles. However, we have seen a few cases in children. Now, the traditional presentation has been face and trunk of children, and most outbreaks have occurred within Central Africa and within southern parts of the continent of Africa. So that's why it's been a little alarming that it's now escaped the regular geographic and demographic distribution. And we in public health, of course, are concerned that if, as we all do, hug and kiss on one another, hug and kiss on grandma, that anybody with a lesion, if we're not mindful, can spread it. So that's why it really is not just for a specific demographic, but for everyone to be aware of and mindful of, especially as we look to opening our schools again safely. We know that children may not always wash their hands or may touch one another and their parents and adults. And so something to just keep in mind as we're seeing some cases among children. One good thing is that we have started to roll out the smallpox, the monkeypox vaccine, which is the same as the smallpox vaccine. And so starting yesterday, we've been administering that to high-risk individuals, particularly within the Black and Brown community here in Los Angeles. So make sure you talk to your public.
May I ask you a question?
Yes,
Why does monkeypox have the label of being related, the so-called gay disease? Why is that?
Great question. Well, I think, like I was showing the vial as well, the vial says smallpox and monkeypox. So part of it is historical, some of it is stigma. So first, monkeypox is a virus that is spread, and it's similar to that in smallpox, which we started vaccinating against as human people in the late 1700s. And so that's really where we get our start with vaccines. And so what we've seen is that the protection you get against smallpox is the same protection that helps you prevent monkeypox. And there's a crossover there too, that protection you have having had monkeypox protects people from smallpox. Of course, smallpox was eradicated in the 1970s. The concern always is that if smallpox is ever weaponized or used as a bio defense weapon, then we would definitely want to make sure that we use smallpox vaccines, and the CDC has stockpiled that for the use in the event of an attack, in the event that people are actually exposed. But going back historically, we've seen with the HIV/AIDS epidemic, particularly hitting the gay and LGBTQ community very hard as early as the early 80s, but the epidemic really taking off in the 80s and 90s. That was a sexually transmitted infection that actually was transmitted in bodily fluid, including blood and semen. This is a little different in that it actually spread from skin contact and not from sexual practices and behavior. So definitely a very important distinction as we caution people not to stigmatize monkeypox as a gay disease, knowing that the vast majority of monkeypox historically has been in children and is really a pediatric infectious illness. So just keep that in mind. But the reason why we are concerned about populations where there are men who have sex with men, members of the LGBTQIA community, because what we've seen are outbreaks, particularly as people have been celebrating Pride Month in June. People have been going to parties and large gatherings. We've really let our guard down now that we're emerging from the pandemic, the COVID-19 pandemic. And so as people are in these larger venues, returning to behaviors and practices that they may have refrained from during the pandemic, we are seeing that spread, and particularly within men who are going to these festivities or parties or returning to these sexual practices. We think about, here in Los Angeles County, we talk about commercial sex venues where traditionally called bathhouses, where people are they're touching one another or close contact to one another. And that is, of course, very concerning if you have these pustules, these lesions, and then they're being spread. And so we really want to contain this spread because we know that it's not limited to gay people and that we will see it spread in all people. It's just a matter of once you're exposed for enough time, we're talking 15 minutes or more, direct skin to skin contact, or someone who is infected, who literally coughs in your mouth. So that's why we will also be currently vaccinating healthcare workers who are working with high-risk individuals. So hopefully that helps unpack why there may be a stigma, why you hear in the media it framed around the LGBTQ community, and why they're being prioritized for the vaccine. But as you know, I'm the vaccine equity, bulldog, if you will, and I'm going to make sure that everybody who needs access gets access. And that's really why we've started to make sure Black and brown high-risk individuals in LA County are now getting their monkeypox vaccines. And we wonder, if we don't control this now, there may be a need for a wider release, a wider rollout of the monkeypox vaccine to the greater community. People over 50 may remember being vaccinated against the smallpox vaccine, but we've stopped vaccinating against smallpox once smallpox was eradicated. So people under 50 really have no protection. And so that's going to be a conversation you're going to continue to see from the Food and Drug Administration's Biologics Committee, as well as those at the CDC's Advisory Committee on Immunization Practices, whether we need to really allow more people to have access to these monkeypox vaccines. And for me, that's a good segue to talk about COVID and where we're at. And since I've last been here, we do have new tools in our arsenal, as Dr. Maxine mentioned, when we talk about Paxlovid, when we talk about Evusheld. Same thing like the monkeypox vaccine, we limited it very much so in the very beginning of those medications, those prevention strategies becoming available. So Paxlovid really was limited to those with the highest risk of death and serious illness, severely immunocompromised, immunosuppressed, cancer patients, transplant patients, those with severe autoimmune and rheumatological conditions on high intensity dose steroids. And so those were the populations that we really were using with Paxlovid. And now today, where we're literally doling them out as fast as we can get our hands on them to anyone who tests positive. And lots of important reasons why we may want to do that. You really do want to end the spread of the coronavirus, COVID-19. We want to limit the course of infection in someone. So what we've seen is in 1 or 2 days, we're seeing that replication stops and viral load of COVID goes down very significantly. That's very important too for making sure we decrease the spread of mutations and the spread of new variants. We've also seen some hints from the literature and data that getting Paxlovid reduces your risk for long COVID, and we're still not sure. Now, months after I've last spoken with your audience here, we're still wondering what is long COVID, and we don't have too much more to report yet. It's still something that's under a lot of investigation. Is this really a constellation or a hodgepodge of actually various different biologically plausible symptoms, syndromes that we're seeing? So is this truly your own antibodies against COVID attacking your own body, and that's what's causing some of these longer term COVID effects, like loss of smell for longer periods of time, loss of taste? We've seen fuzzy brain, fuzzy memory. We're seeing nerve issues with extremities, people feeling chronic fatigue that they did not have before. We're even seeing that in very healthy young people, including athletes who are not taking any medications, have no comorbidities, and now living with severe fatigue and not able to return to much of their regular lives, including for those that are athletes, their professional duties as athletes. So that's something that is very interesting and alarming. And we don't exactly know why. Other questions are, could COVID-19 be lingering in people's bodies? And that's, again, maybe one reason why using Paxlovid and other antivirals is helpful, because maybe it is killing any dormant virus that may actually be in your body as well. There's also questions about, is some of this actually just long-term damage that the actual initial infection presented, and it's just going to take, as we talk to our patients, 6 weeks to 6 months, or even a couple of years to really return to baseline, with certain tissues in your body, parts of your body, just much longer to heal. We're also wondering if this is some sort of inflammatory process that could be affecting the vasculature in people's bodies. And so wondering if, when we look at cardiac events and cerebrovascular events, is that a connection there? We have seen associations between histories of COVID and increased risk of stroke and heart attack and other cardiac diseases and infirmities. So we want to be extremely mindful of that. All very important reasons why, to Dr. Maxey's point, if you haven't gotten your first and second shot, please do. For those eligible, everyone's eligible for a third shot, a booster shot. That please don't delay. There are many who are now eligible for fourth doses, and you see publicly the CDC having those discussions that soon they'll probably be recommending fourth doses for everyone. There's a lot of debate as to whether we will get to a fifth dose to high-risk populations. Still not recommended, but we know that that is a practice happening within the infectious disease and the vaccinology community for those that we want to protect. Many people have had their fourth dose months ago, and if the mRNA vaccines, Pfizer and Moderna, the data showing only really lasts in your body 4 to 6 months, those individuals may actually benefit from a second booster shot, a fourth shot. What we've also seen, fascinating enough, is this roller coaster ride of a journey with Johnson & Johnson, where we used it, we stopped using it, they let us use it again. We were concerned about these clotting issues that both AstraZeneca and Johnson & Johnson presented with. We were worried about these thrombi in the brain. And then with enough data, we issued a warning and then continued to vaccinate even people that may be at higher risk. We were talking about women 18 to 44 at the highest risk of that complication. But we've been using Johnson & Johnson. What we're seeing over time was that Johnson & Johnson was also less effective at really preventing serious illness and death. But now data shows that it actually stays in your body longer. So is that a consequence of a viral vector vaccine? Are they more effective at staying in your body longer versus Pfizer and Moderna, which most data shows 4 to 6 months, you really have no protection after that point. So these are all things that cause us to now be in some murky water of what the right thing to do is. So again, I'll just say the right thing is, of course, get your first and second doses. Please be sure you've gotten your booster shots. Make sure you're fully protected. And if you're eligible for that fourth, you get it. Beyond that, there's no clear recommendations, and that's a conversation you should have with your individual care team, clinician, physician, and discuss whether maybe you would benefit from a third booster, or maybe should you have a conversation if you're a candidate for Evusheld, which, just like in the HIV world, we use pre-exposure prophylaxis, PrEP. We use both by mouth and now long-acting injectables, Apretude, for the prevention of HIV. We have Evusheld, which is a pre-exposure prophylaxis, combination of 2 monoclonal antibodies. And what we've seen with the data and the FDA and the CDC approving its use to prevent COVID-19, and we believe that protection is good for at least 6 months. We are giving that to cancer patients, transplant patients, patients with autoimmune conditions. But we think that also, Evusheld and Paxlovid, may benefit populations beyond those at the highest risk. So there's an ongoing debate whether we should open up the eligibility criteria for accessing Evusheld, because we may see people in their 7th, 8th, 9th, 10th decade of life benefiting from having this type of protection, monoclonal antibody protection, especially if we're concerned about people's immunogenicity, whether they're really able to react and provide the appropriate response to vaccines. You may actually want to provide those individuals the actual antibodies themselves. And so that's going to constantly be a debate. And as we've talked about before on this channel alone, everybody, literally every single human being's body is different. And that's a big part of why it's so hard to come up with a one size fits all blanket statement that works for everyone, because, you know, whether it's a vaccine or whether it's the treatments, they don't actually work that way for everyone. So just some clinical considerations for those that are definitely in the health and medical space, but as informed patients, as informed, you know, for better or worse, we have to use that awful C word, consumers. You know, you really have to have all the information so that you, just like going to Walgreens or Walmart or CVS, when you go to the doctor, the hospital, the clinic, you should have all the right information so you choose the right recommendations for you. Ultimately, our job, as I always teach my residents and students, is to really be that GPS and that navigator in that vehicle with you, sitting by you and giving you the best information, recommendations, guidance that we can. But ultimately, I want you behind the steering wheel. I want you driving your life, and we're here to make sure that you have all the tools to do that. And our goal always is your best life, your highest quality life, your longest life, your safest life, your happiest life. And those are the goals of living. And that's, I'm sure, why we're here today on a Sunday morning, so we can make sure we learn and can really have all the tools so we can do just that. So I'm gonna stop there to see if there are any questions. I see there are some questions coming in from Dr. Sherrod, a big fan of yours. Thank you so much for always being there and sending patients our way. And in fact, you've even helped us find staff in our greatest times of need. So I appreciate that. I'm trying to think really quickly. Dr. Maxey, Dr. Nabrit, Stevens, Dr. Walks, are there any big issues? I'll see Dr. Jordan on the line, who is our HIV/AIDS preventionist and treatment hero. And so I don't know if you have anything else you want to chime in. I know there's a lot of analogies between HIV and COVID, and now with monkeypox on the radar, remnants of a past time. So I'll open it back up.
So thank you so much. You always give so much information. I got to figure out how to get it all written down and redigest it. Dr. Neighbor Stephen and Dr. Walks, I know you have some comments and questions for Dr. Abraham and others may. Dr. Neighbor Stevens?
Thank you so much, Dr. Abraham. Not trying to put you on the spot, but
Yes, she is.
I'm going to ask you though to look into your knowledge base and come up with the response to what I'm about to ask. So as this is almost the end of July, moving on toward the fall, and as we always have our waves of illness in the fall and winter, what are you seeing as a strategy that we need to be seriously considering, given the information that we know? And as you so clearly pointed out, there is still so much we don't know. But given what we do know, what kind of strategy would you put forward for us to be considering going into the fall, vis-a-vis dealing with these viral infections? And I would include influenza in that as well.
Great. Thank you so much for that question, Dr. Nabrit. I'll start by saying bigger framework here, that 30,000 feet in the air perspective. The times are changing, as is our planet. And as we see extreme heat patterns, as we see extreme weather, as we see these fires right now in California and in Europe, we know that this is contributing to some of the changes that we're seeing with these infectious agents, viruses, and bacteria that are also a part of our ecosystem and planet. And so just like we're changing to mitigate and adapt to the ever-changing climate, so are the microbiome and all of living creatures here on this planet. And that is why I think we've got to really learn from this pandemic, because the skills that we equip with ourselves now will determine whether we live or unnecessarily suffer and needlessly lose lives in the future as we continue to deal with other pandemics. And so I think that's why watching this monkeypox outbreak closely is critical. And there's going to be a lot to learn. So from HIV to COVID to now monkeypox, these things are going to happen more often. I think it's very important that we protect ourselves. And so when we think of that broader strategy, we were anticipating a spike here in the summer, and that's kind of what we're seeing now. Not only here in the US, not only in Europe, but now we've seen a new Centaurus strain coming out of India, moving to Australia. Will that move to the Western world, including Western Europe and the United States? Yet to be seen if those will spread and become dominant strains. It wasn't too long ago that we were just dealing with Omicron, and now sub-variants of Omicron have become the dominant strains, BA4, BA5, now BA5. Both of these highly infectious, more infectious than the previous strains of COVID, more infectious than Delta, more infectious than Omicron, now BA4, BA5, really spreading disease very fast. What we've seen in general, though, presentation's a little different, definitely mild disease. We haven't quite seen increases in deaths, although we've seen some increases in hospitalizations. We're still monitoring it. There are pockets where we are actually seeing increasing deaths. So we want to be mindful. That's why it's so important that we don't entirely let our guard down and pretend like nothing's going on around us. I will also say that with BA5, we've seen more sore throats, mild cough, cold symptoms, lingering cough. We've noticed that Paxlovid is effective in its treatment. We've seen that anecdotally, it seems like once people test positive, there are more people that are symptomatic than previously, where we were very concerned about all of the asymptomatic spread. That's happening still too, but we are noticing that most people that are testing positive are having some sort of mild illness, some symptomatology. That's fascinating. I think what we're going to watch with things like Centaurus moving forward, if they actually deem it a truly a new strain with a new name, it'll determine, whether there's more hospitalizations or more fatalities. And also the reason why we're watching what's happening in India and Australia so closely is that just like Delta had so many mutations in Omicron, this latest one has more mutations than ever before from what we were used to with the spike protein and actually other parts of the coronavirus itself. So this is one of the challenges with the traditional cough, cold viruses when we talk about coronavirus, rhinovirus, some of these human metapneumovirus, these families, adenovirus. There's a few others in this category. They are quickly mutating, particularly rhinovirus and coronavirus, and that is one of our concerns. So that's part of why we're struggling to keep up, and why, is the strategy are we better off with monoclonal antibodies as treatment or prevention? Is antivirals and treatment after people getting infected the best strategy for preventing the spread? Because if you don't have virus in you, you can't spread it. And if antivirals kill the virus in you, that may be best. So it's still, as you mentioned, Dr. Nabri, still too early to say definitively what the best strategies moving forward are. But we do know that as long as it is spreading, it continues to mutate. And as long as it is mutating, there's always that risk that we're dealing with something more severe, more deadly. And even when it's mild, we know that whether it's the pneumonia or flu and even coughs and colds, they are devastating for people that are transplant recipients or those that are on immunosuppressive therapies, those that are living with very serious illnesses. We know that our grandmas and grandpas, we don't want to lose anyone too early unnecessarily. And so that's why I really want all of us to continue to have that high level, that awareness, that accountability to one another, because we do all play a part in making sure that no one suffers and dies from COVID that shouldn't. I don't want any of our kids who have cancer catching it unnecessarily. We know that there are people that can't get vaccinated for various reasons. There are lots of groups that we really want to work really hard to protect, and that's very important. I will say we're probably going to get through a summer wave, and then the question is, how do we ramp up and prepare for the fall and winter? And that's where advocacy does come really into play. If these mRNA vaccines, these newer technologies are supposed to be a platform that are innovative and can bring to market rapidly, next generation vaccines, well, where are they? Where are the next generation Modernas and Pfizer? So that's when we need to continue to apply pressure to the pharmaceutical industry and on our government to demand that they had promised that we would get Delta, next generation vaccines, now Omicron vaccines. Well, those haven't come to market nearly as fast. And now we've had plenty of time. So there's really no excuses. We've seen a lack of funding, a lack of prioritization by both the federal governments and states on this, and that we always are concerned that by the time they take it seriously, it'll be when we're in the thick of it with high numbers, high hospitalizations, or high deaths, and then trying to roll out a vaccine like you saw, if we don't get it right, causes all the travesty and the chaos and unnecessary, just suffering like the last go around. So that's something that we really want to see. But I still say, get that third and fourth dose. I hope that we get some next gen vaccines, but now the earliest we're looking at is November, is what we're hearing from those at the CDC and the FDA. We're still working tirelessly to get the kids vaccinated, because now 6 month to 4-year-olds, 5 to 18 can get booster shots. School opening is around the corner. So with smallpox or with monkeypox, apologies, and with coronavirus, we just want to make sure that our kids are fully protected as they go back to school. So lastly, I'll just add, as we deal with these summer peaks, we're going to summer camp, we're traveling, family vacations, be mindful who you're around, be mindful of who's vaccinated, who's not. When we're around sicker or our elders, let's be mindful to wear masks and to make sure that we're not exposing them to illness. As is always good practice, continue good hand hygiene. We know it's spreading in our airports and airplanes, so be mindful if you're planning on traveling. And I still think hand washing, masks are part of our strategy, social distancing when appropriate, because these large gatherings are clearly places where a lot of exposures are happening. And then lastly, I think we're not doing enough testing and isolating and quarantining when we're exposed or when we're positive. And so that's a critical piece that I think we've let our guard down on. And when it comes to testing, because we're doing so much at-home antigen testing, we're clearly underreporting the numbers. So they're much higher than you're seeing in the media, than the CDC or Johns Hopkins or the Institute for Health Metrics and Evaluation at the University of Washington can keep up with. So just keep that in mind. And we're trying our best to do some of this monitoring through wastewater and other creative strategies, but that's really not a strategy for figuring out how much COVID-19 is spreading throughout the whole nation. Those are in very specific urbanized pockets where they have that luxurious resource, and we're not capturing all the COVID even in wastewater. So those are some of the considerations, but I do think now is the time to get everything, get your house, get your immunology in order so that you can have the best chance, not only of survival, but just being healthy through the fall and through the winter, where we do expect spikes, not only in COVID, but also again in the flu and pneumonia. And we're gonna make sure that everyone gets their flu shots and COVID shots, and we'll be combining those for sure. We've already been doing that since the spring. So we'll really be rolling out heavy, making sure all the kids get all their childhood vaccines and that adults get their flu shot and their COVID shot, the COVID boosters this fall.
Yeah, thank you. Dr. Walks.
Dr. Abraham, I sit here and I listen to you, and I'm just impressed because you have a way of grasping the bigger problem and the hard science and then presenting it in a way that folks can accept. And I just think it's a huge, just a huge resource to have, that you can pull on that connection to the community as well as the science. There was a comment in the chat, and I've been thinking a lot about this whole, what are people struggling with? And you've been on and talked about this before, but what are all the other things that people are trying to deal with that make them say, you know what, I don't know what's going on with that COVID stuff. I know 4 people that got it and they're okay. And now they're talking about monkeypox, but it looks funny, but if you get it, it's gonna go away. And so why are people trying to get me to worry about all of these things when I'm looking at trying to get the rent paid, trying to deal with food costs, with gasoline costs? I think it's as a former public health officer, it's a challenge to get people to focus on public health, unless you're in one of those sci-fi movies where it's something, everybody who gets it is dropping dead. We're not there, and we were worried about these different variants, and now that all the variants have come, we're still not there. It's not that every variant is killing everybody. And so I wanted you to just kind of think out loud with us, if you can, about how do we carry a message that will resonate so that folks, with all the other things that normal people, all of us are dealing with, that this message breaks through. And one last comment to complicate the question is last week we talked about how the major killer in our community, it's not COVID. It's lung cancer, it's other sorts of things that have been around for a while. Everybody's got diabetes and having problems. And so when we continue to tell people that this COVID is something, it just makes me say, how do we get a message about just health infused into our community? And then this on top of it, I guess, is the way we go. So again, I'm sorry. I know this science is important. I know these things are very important. And at the same time, the other stuff matters too.
Great question. All right, so I'm going to try to tackle it because there's a lot there, and I know we've got limited time, but I'll go fast but slow if that makes sense. And we really do want to break it down. I'll start by saying this is a Sunday, traditionally known as the Lord's Day. So we always need to hear a little sermon on a Sunday. So I think about the miracle of loaves and fishes and not always having enough. And I think that is part of our challenge still, is figuring out how we need that miracle where we realize there is enough health and healthcare for everyone. And we need to figure out how to distribute that to the multitude that are sitting on the hill right now as we're gathered together. And so we need to come together in community like that. And I believe that miracle can occur. I also think about when we think of Noah's Ark, I wonder, he can be out there getting the animals on board and saying there's room for everyone, and people still don't listen. And at some point, those floods do come. And unfortunately, sometimes, as we saw with the COVID-19 vaccine, there are people who didn't get it and did pass away, and there were windows of opportunities they should have gotten on board, but it was too late for those individuals. And that's really the truth in that, allegory with Noah's Ark, that people do miss the mark. And I don't know if, that talks to more of our human condition, or, I hate to use the word, but I think about words that my past pastors would have said, and it's foolishness, right? To have all this information, to have a boat, to have all the tools, to have a leader like Noah telling you to get on, and you still don't listen and perish as a result. And so we want to make sure that we don't fall into those traps. And those traps include the traps of misinformation, disinformation that's spread. It's so important that each one of us squash that, because ultimately people take some of that information and it's feeding into their psyche and their relationship and understanding of what is the right thing to do. So we all have a role to play to make sure we tell people, we know the data shows vaccines work. Many of us have been fully vaccinated, gotten third and fourth boosters. None of us have grown a tail. 5G technology, we're not magnets, we're not mark of the beast, we're not all of those things that I always hear about from my patients, microchipped and this, that, and the other. So none of that has come to fruition. So I think we really have to remind people, let's bring it back. Let's shed some light and make sure the truth is at the bottom of. That's why the data and science have to be still core on the grounding. Just like when we talk about going to church and you ground yourself in scripture, we got to ground ourselves here in science. And so, to your point, as public health emissaries, ambassadors, missionaries, we really have to spread this good word of that public health works, and that we're going to sound a little bit like Noah, and it's going to fall on deaf ears. And for some, they're going to wait until it's too late. And that is a challenge. And those are things that we want to continue to work on. But I do hate to think that it is catastrophe. It is death. It is feeling that stress and pressure that makes people change behavior. And we've got to find a way to apply some pressure without them feeling the agony and the pain and the loss. And I think those are things that behaviorists, really understanding neuroscience and the way our brains work, really will help us in the future figure out people's motivations. And that's true. If your motivation is, I need to put a roof over my head or put food on my table, take care of my children, I don't have transportation or childcare, elder care, I'm still worried I'm going to lose my job, or I need to get another job. Those are all things that are going to take priority, which is why for many of us that work in primary care and public health, we do think those social determinants are so critical, ultimately dictating the outcomes of my patients and their lives, not whether or not they swallowed a pill that you prescribed for them. So really getting people to understand how much of an influence these other factors play on whether people do what I mentioned earlier, which is best life, longest life, happiest life. Those are the critical things that we've got to figure out how to prioritize. And so still a long way to go on that. And so to that end, what we've done here at Kedron is we definitely are changing our model. We're talking about going from pandemic to endemic. We're talking about post-pandemic, post-COVID world. We now go out, instead of providing vaccines and testing, what we're doing is we're coming to you with health, and that now includes diabetes screening. So we're doing the A1Cs on location. We're doing the lipids for everyone. We're doing everyone's blood pressure. And then if they want to get a COVID booster, or if they would like COVID tests, we've got all the COVID services. We bring Paxlovid wherever we go. So they have the one-stop COVID shop, but it's not the highlight, because I agree with you. The number one killer of children in the United States right now is gun violence. If I'm not talking about that, then I'm doing a disservice for our children. Same thing with the adults that I'm treating, high risk Black and brown individuals in South Los Angeles. If I'm not dealing with their diabetes, the trifecta, hyperlipidemia, and hypertension, then I've missed my mark, and they've missed their care for 2-3 years already. So we're really trying to figure out innovative ways to take this fleet of vehicles out there and really start with the foundations, the basics. We're doing produce giveaway, hot meal giveaway, get all of these points, these health markers for yourself. So now we've got the information. We have not had GPSs for ourselves. My patients are not walking around with fancy smartphones and fancy iWatches that are telling you all that data. So what you see, even if depending, regardless of your upbringing, your education status, if you give people that information, it all of a sudden makes them go, doc, is that normal? Is that okay? Is it okay that my blood pressure is that high? And it's a conversation that maybe they've never really even thought or have had. And that starts a whole nother journey for them when they try to work towards improving their health. And also just being able to diagnose and reach people much earlier. I really think prevention, screening is such a critical part, and linking people back into care. And so I do want not COVID to go away. I want our services to be with us, but I do want people to be reminded that we've got so many other things to focus on as well, and that they're all important, and I can walk and chew gum at the same time. So we'll do it.
Thank you so much. That's wonderful. And yes, I agree. All of it, all of it works for me. I think I see Dr. Jordan has his hand up, Dr. Maxey.
Hey, Dr. Jordan. Can you make sure Dr. Jordan's unmuted?
There he is.
Can you hear me?
Yes, sir.
Okay, I have a two-part question, and thank you for this presentation. Part one, has there been studies to show that people like Dr. Maxey, who had their smallpox vaccination in 1910, still have some immunity? And part two, when we look at HIV in the Black community, what is the best way of recommending a monkeypox vaccination for HIV positive patients, since so many of our patients do not admit to having engaged in a same-sex act?
Okay, great question. First question, there is data that shows those with the smallpox vaccine, which should be people over the age of 50, and you probably would know because you have that scar on your shoulder,
Right,
on your thigh. Those folks, there is evidence that they have some protection against monkeypox. Now, the question always is, do people benefit from some sort of booster? And I think that's where the jury is still out, and we will find out what the recommendations are. But right now, for those, when we do the screening forms, which, I have a tool here and it asks the questions, it's, right now, those with the smallpox vaccine would be excluded from our monkeypox program. Right now, we're doing the first dose, and then the second dose is 28 days later. We are curious, will there be some sort of boosters for those 50 and older, and how susceptible are they? And as we mentioned earlier, for when we talk about virology and immunology, it's really something. The microbiology of all of this is, could this turn into a more severe illness? Is really why I think we have it on our radar. It's definitely a virus that doesn't mutate as quickly as coronavirus and rhinovirus. So I think that's one thing that we've had some assurance of, but we want to make sure that people are protected, because we wouldn't want people that are older and we're telling them they don't need this vaccine, and then they do get sick or end up with hospitalizations unnecessarily. And it's that balancing act, to Dr. Walk's point, of, the health. As I teach, again, the residents and students, I'm constantly, as a family physician, grappling the health of the public and the health of Mrs. Jones right in front of me. And doing what's right for Mrs. Jones is not always the best thing for all of society, and doing what's right for society leaves several of my patients behind. So I don't know the right answer, but it's clearly a balancing act. To your other point about behaviors, I want people to be honest. I want to create openness. That's why that, whether you want to call it the exam room, there's a sacred space between clinicians and their patients, and it should be so private and so protected. And we know right now with the Roe v. Wade discussions and all of the issues around reproductive rights, it's under attack. But we need people to feel comfortable enough to tell us what's going on, be honest with me. If we can all be honest with each other, then we can make the right recommendations for you. And we are very mindful, even as we literally are going to bathhouses with the public health department and vaccinating people. You see, it's changing people's minds and their relationship, because they go, you came out here for me. You didn't want me to be left behind. They're like, the way our teams approach people too, just that we are not here with any judgment at all. We are here as agents of truly mercy and help, and we want to make sure that no one dies or suffers. And when they see that, I notice they are much more open to talking about other health issues as well. And they really do see who they thought were their foes and enemies, and you work for the state, or you are a part of that big old machinery that steamrolls over all of us. They realize, oh no, it's actually the Dr. Jordans and Dr. Abrahams and Dr. Maxey's and Dr. Nabrits and Dr. Walks that are behind every one of those, that care that's given, and that we really care for you and we want to help you. And so I hope you feel comfortable enough to tell us about risk factors and practices, and so that way we can care for you better.
Well, thank you. Dr. Neighbor Stevens, are there any questions we need to address in the chat?
There was a question about the new Novolog the vaccine. So if you could comment on that. And then you mentioned several times the smallpox, monkeypox vaccine. There is a question about, is that approved for use in children?
Okay, great. So I'll answer some of these questions. Novavax, of course, has now achieved the CDC Advisory Committee's recommendation. The CDC itself now recommends it. Went through the FDA process. It's a protein-based vaccine. So we just kind of rewind and review. Johnson & Johnson was more of a traditional adenoviral vector vaccine, similar to the flu shot. Then we got these newer technologies, this mRNA platform that allows us to bring updated vaccines to market much faster, particularly Pfizer and Moderna. And we're waiting on those next generation vaccines. Well, now we've got a fourth in our arsenal, and this is Novavax. It's a protein base, so literally just identifying parts of that spike protein and then putting it in you so that you can actually create the antibodies against it. And so that for many that are uncomfortable with the mRNA technology, this protein-based vaccine seems to be something that has lower risk potentially and may be most effective for those that feel uncomfortable. There's still plenty of people that come out and tell me, Doc, no matter what you tell me, you're putting mRNA in me. And, at least theoretically, from what I learned in genetics, mRNA can reverse back into DNA. And so you just got people that are committed to believing no matter what we do with mRNA, it's going to somehow end up altering their genes.
Can you unpack some of that just a moment? Just remind us what mRNA vaccines are, what adenoviruses are, just at the lay level, so we can just make sure we understand what you're saying.
Well, I mean, as we mentioned earlier, we really started vaccinating people in the late 1700s. against smallpox. And then throughout those now 200 some years, we've really improved upon our vaccine technology. I talk about epochs throughout human history, starting with, just getting nutrition. We were dying from starvation. Then we got to a place where it was maternal and child health and surviving pregnancy, surviving childbirth, surviving those first few days of life. We got through that. Then it was, moving on to things like infectious diseases. And most in the, let's say, first world, high income world, we've now moved past those, even though we know people around the world still suffer from HIV, tuberculosis, malaria, and other neglected and tropical diseases. But for the most part, we've moved beyond that epoch of infections, although now it's rearing its ugly head now with things like coronavirus and maybe monkeypox. We then got to this place called the epoch of these chronic conditions, non-communicable diseases, diabetes, heart disease, hypertension. And now we've got good treatments. And so something we didn't talk about, and maybe we'll say this for a future date, is the role that injections will continue to play. And so those with needle phobia, those that are afraid of going to a clinic, these are going to become more critical issues as more of the best treatments available will be injected into you and be long acting and long lasting. And what are the impacts of that, and who will get left behind, and who will have access to these very expensive, innovative therapies that can really help people live much longer with chronic conditions. But once we survive diabetes and blood pressure and hyperlipidemia, we really get into this epoch of cancers, the luxury of living so long that we're all going to get prostate cancer, colon cancer, lung cancer, breast cancer, and we're seeing that. And we're excited that there's so many survivors, but we've got to work harder at preventing cancer. And so now we've gotten that far. Well, what comes after the epoch of cancer? You really get to this epoch of neurological conditions. And that's for those that have the luxury of living their 8th, 9th, 10th, maybe even 11th decade. Maybe one day it'll be the 12th decade. But if we can figure out how to live with neurological conditions, as you hear more and more medications coming out for the treatment of Alzheimer's and other neurological conditions, we may one day have the luxury of seeing some other epoch well beyond that time period. So that just gives you a framework for the way I think about many of these things. So when you look in there, especially that infectious disease epoch, we really are talking about the most powerful innovation there were vaccinations. And so because of that, as you may have heard recently, there was a case of polio in New York in an unvaccinated person, first in a very long time in the United States. We know there are people around the world that still live with polio, but here in the US, you don't see that. And so why? Because we got vaccinated. Same thing with smallpox. It was a very fatal illness, but because of the vaccine and the eradication of smallpox, no one dies from smallpox today. So these are all testaments to vaccines, and all those childhood vaccines that we give our children save lives. And we know they're very safe. And we use so many vaccines and there's so much data behind them. So, of course, debunking myths about autism and vaccines or long-term effects of vaccines. I'll remind people, Dr. Maxey, as you're suggesting, when we look at the vast majority of issues around vaccines, they happen within 24, 48, 72 hours. They're mainly allergic reactions to ingredients. Those ingredients we always have listed. Usually any vaccine site has a paper with the ingredients, and we're giving that to you. So it's pretty clear who is going to have a serious reaction. There are people with certain allergies to certain ingredients, and those people that are contraindicated for vaccines. And that's why we carry EpiPens with us when we're at vaccination sites. And after 400, 500,000 vaccines now at Kedron and the programs that I operate, we have not actually had to use one EpiPen. And I personally have not sent anyone to the hospital as a result of the vaccine. So I do really want to just make sure that's clear to people. There are lots of other reasons why we see some of the vaccine safety data is just, again, very important to show. We always talk about, is there a link between vaccines and cancer? No data suggests that. Vaccines and later autoimmune conditions, we have not seen any link like that. Vaccines and affecting reproductive organs, again, haven't seen that, or affecting fertility or pregnancy. And so just really want to remind everyone how safe vaccines are, and that safety remains a top priority. And it's independently reviewed. Not only is the CDC and FDA looking at that, but there's so many groups that independently review the safety data, and we're all constantly reporting into these data systems so that even for the smallest adverse reaction, like we saw with Johnson & Johnson, where there was some very small handful of individuals, particularly women between 18 and 44, that had that blood clot in their brain, they literally paused the use of Johnson & Johnson immediately until they could confirm that we knew what was going on, we knew how to treat it, and what did they do? As soon as we deemed it safe enough, we unlocked it and allowed it to go on. And so to that point, I did want to answer Dr. Sharad's question about, what about people that are having long COVID-like symptoms after vaccines? It's really hard to say for sure. I will tell you from my experience, I don't see the vaccines causing these symptoms. I know people have reported, well, after the vaccine, I got this cough, or after this vaccine, I've been fatigued for months. It's very difficult to say, but I will tell you, I don't see that relationship between the vaccines and those symptoms. In fact, I might actually say the vaccines can prevent long COVID-like symptoms or reduce long COVID-like symptoms. And I do think that the risk of COVID-19 infection, and this is really important for everybody on the call to hear, reinfection increases your risk for long COVID symptoms. So to reduce that risk of multiple reinfections, we've seen people now with 3, 4, 5 times being infected with COVID. They're at the highest risks of organ involvement and other complications and long COVID. You really want those booster shots. And we're seeing the people that are getting reinfected the most are the ones that are vaccinated or haven't got these boosters. So just keep that data in mind. And so what we'll say is that the consequences of COVID definitely far outweigh the risk of the vaccine itself. And what we've seen, even in the case of pericarditis, inflammation of the heart, was that the risk of pericarditis in COVID-19 is actually greater than that of the vaccine. So actually you're better off getting the vaccine. But that's the nuance. That's the challenge. As you're saying, break it down, go back to the basics. That's a hard thing. But when we take the time, as you see, I couldn't do that in just 2 seconds. You got to sit down with patients. You got to give them that information. And based on that, often, or maybe 15 or 20 times after talking to them, they finally decide to go in and get the vaccine. I hope that gives some comfort to you, Dr. Sharp, because I know those are frustrating. We hear those anecdotes all the time, and I don't want to dismiss people's experiences. I have not lived in literally their shoes, and they may be experiencing that. But as we see with a lot of other issues in medicine, often there are many things going on, and sometimes there is it is a coincidence that they got the illness at the time of, or we see that with the flu shot as well. People who got the flu at the same time as they got the vaccine, and now people say, oh, I got the flu shot and I got sick. So you got to figure out how to tease some of those things out, and we're working harder to get better at that. And lastly, Dr. Maxey, adenoviral vector vaccines like Johnson & Johnson, like the traditional flu shot, they take basically a plasmid or a dead viral shell just to get that into your cells. And once that's in there, the information, usually the protein that your body recognizes, can then be recognized by your immune cells and produce antibodies in your own body. What we're doing with the new Novavax is we're not using that plasmid, that viral vector. We are literally just giving you the protein, and they figured out a way to be able to get that into your body and still make antibodies. And that's the benefit of Novavax, is you're now not even using that viral shell. The mRNA platform, what's nice about that is it's a piece of information. It degrades within a few hours. You put it in, your body gets the message, then it starts to replicate that protein, then that protein is recognized by your immune system, and then that you generate antibodies. And what's good about all this is we can study and follow all this. For each of these, you can see literally how long it takes for individuals to actually have COVID antibodies after injection with vaccines. And so it really shows you they all are effective, just some are better at it. And the mRNA vaccines have been best at getting your antibody levels highest. And that may be because of the mRNA technology, we're giving the information, and then from there, your body takes off and starts with all of the machinery that helps you make proteins. And maybe that recruitment is what allows it to be so effective. I'm sure we're going to continue to learn more about why and which technology for vaccines is far superior. And so also we just want to be mindful of, like, a lot of those reactogenicity issues. People felt swelling in their armpits, or some in their breast perhaps, or maybe people felt more feverish or tired. fatigued right after the vaccine. Those you don't see as much with Johnson & Johnson and potentially with Novavax. And so those are reasons we may choose Novavax. I'll just answer the other question about monkeypox in children. We haven't made any recommendations yet for people under the age of 18 to get the monkeypox vaccine here in the United States yet. So still too early to say what those recommendations would be, but we are not anticipating that the monkeypox vaccine would be something that would be rolled out to children anytime soon until we have a better grasp. Monkeypox is pretty self-contained, so if you were to go to the hospital, there's not really anything we would give you, although there are some antivirals like medication that we would use for HIV that may help stop the replication of monkeypox virus in your body. And so it's still something hard to see, and that would be very limited to those that really are seriously immunocompromised or immunosuppressed. Hopefully that was a lot and very little, and got some of those questions answered. Dr. Maxey, Dr. Nabri, Dr. Jordan, and others, Dr. Sherrar, Dr. Walks. Turn it back to you.
Thank you. One of the questions I want to ask you before I invite somebody else to speak that you can answer. Back when I was 5 years old and Dr. Jordan was 18 and he used to walk me to kindergarten in 1910, in his exposure, should he be recommended the same medication you gave me because of his relative risk in AIDS? And I had been pronouncing and spelling the medicine you gave me wrong, but I told you I was going to the National Medical Association and you gave me a choice between another booster and a medication. Maybe you can explain that, and I want Dr. Jordan to listen because he's 15 years older than me.
Oh, Lord. Okay. Well, I'm gonna try to stay out of the school playground. Yes, tits. But I would say it's a complicated question, Dr. Maxey, and that's one where we really need to sit down with the individual and understand their risk profile, and based on that is how we would make that determination. One of the challenges with these monoclonal antibodies are that they, as soon as the virus mutates a lot, they become ineffective. So many of those earliest monoclonal antibodies we don't even use anymore. There was one that was touted as like the Delta monoclonal antibody, sotrovimab, and that quickly was discontinued. We're still using remdesivir IV in the hospital setting and even in infusions and outpatient settings, and that's still holding up pretty well. What we have here, and what you're speaking to, Dr. Maxey, is Evusheld. It's a combination of two specific monoclonal antibodies. They're 2 shots given at the same time, 1.5 cc's of each. And so far, the data has been holding up well, that they have been effective at reducing people's risk for catching COVID, catching serious illness, and dying from this Omicron variant. The issues here is how long is that going to hold up if we keep seeing more and more mutations. But so far, it's definitely been recommended, and we're using it in people living with HIV/AIDS and cancer patients and transplant patients. And there is a robust discussion as to whether Evusheld, Paxlovid, we now do give pretty, make it widely available regardless of eligibility criteria. Evusheld may be something that we move in that direction at some point, but it's that murky water we spoke of earlier. I think based on risk profiles, more people would benefit from Evusheld than they currently are recommending its use. And so that's something I want to keep in mind. I do think most importantly, in addition to getting vaccinated, if you catch COVID, please get help and get those, get Paxlovid. And if you're at, real risk of dying or being really sick, then you probably should get that IV remdesivir. But so far, just like President Biden, just like many others, Paxlovid seems to be a great stay. And I think that's something that, we might find out, just like we do with over-the-counter Plan B for, preventing pregnancy, or we see other medications that we can access more easily, we may come to a place where you can just go to a pharmacy and say, I've tested positive, give me some Paxlovid, or maybe we'll even prophylactically, like pediatricians might write a prescription for antibiotics with certain certain bacterial infections like strep throat, for example. You might write a Paxlovid prescription, say, if you test positive, go take it. So those are some of the challenges and the counseling required when it comes to HIV meds. Here we're talking about COVID meds. It's case by case who would benefit. And we see that all the time. Now there's long-acting injectable HIV medications, but they're not always covered and they're very expensive, $4,000 a shot. Now that's pre-exposure prophylaxis. You get it and you don't need it again for a couple of months. It's pretty cool, but not at $4,000. And so some of these options aren't always available to everyone. What's great about Evusheld and Paxlovid, we've already paid for them as taxpayers. So they're free for everyone, just like the vaccines. And hopefully no one's bleeding money out of their bank accounts for tests, because there's so many free testing resources all around us in our community. And I really want everyone to hear that please don't be wasting or spending money on COVID, because there's still so many free COVID resources in our community. Hopefully that helped answer that question around Evusheld and remdesivir or Paxlovid is right for you. Paxlovid we are using. There are recommendations for using it in children. So basically adults and even some children benefit from taking Paxlovid. And right now the Society of Maternal and Fetal Medicine, our obstetricians and gynecologists do recommend it even in pregnant women at high risk of complications. There was one other medication that we don't talk about as much now. It's molnupiravir. That kind of also fell to the wayside just because the data on Evusheld when it first came out was 97, 98% effective. Now, as you presented, 89% effective. Molnupiravir started in the 70s and continued to decline. So that's why we don't use that pill so much. But this treatment gauntlet that we're going through, there's just so many names, so many new medications, and they come, and before you blink your eyes, they're gone. And so it's even hard for clinicians to keep up with. And that's one of the challenges that we're having is how do we teach, particularly in underserved and underrepresented communities within Black and Brown patients serving and Black and Brown clinicians, making sure they have all the right information, because we know that if people know about Paxlovid, they would get it. And we're seeing Paxlovid used the most in white and Asian and wealthy communities. So how do we increase clinician prescribing behaviors of Paxlovid by Black and Brown clinicians and by those serving Black and Brown patients?
Again, thank you. So we're coming close to the end of our program. So I want to make sure that our co-moderators have a chance to see if there's anything in the chat and anything else we need to ask you and discuss. Dr. Neighbor and Dr. Wallach.
I think we got everything. But I do want to go back to two things. One thing at another time, but and that is the whole question of health and how our community takes health for granted. It is said more politely, it's a lower priority, that there are other, but there's a lot of taking it for granted involved. And I would love for us to talk about that a lot more at another time. But I want to go back to, you appropriately addressed the need for Paxlovid in those who are at high risk and or who are of advanced age. But you also said, and it's true, that when you have more, especially if you've had a second case of COVID, that does start moving you up the list in terms of risk for long COVID. I don't think young people understand that or know that. And I know that there is conversation that BA.5 is milder than what we have seen before. So the discussion that I've heard has been, it's not, you're not that sick, why bother? So if you would just kind of speak to why young people who are probably the ones who are getting it more than once, because we know that the boosters are not protecting infection from BA.5 and they're out there, so they're getting BA.5. Would you speak to that question of Paxlovid and the younger generation?
Yes, and I definitely do want to come back and speak at some point about some of those issues you talked about. How do we get our community to prioritize health? And I think one thing is if we can figure out, just like the church model or even the school model, we learn together, we worship together, we dine or eat or play together. When you go to church, I think that there's something communal about worship, or even imagine some churches where you have to go up and put your money in the offertory plate. So there's accountability with one another. We've got to figure out a way to translate that into our communities where we all go to the doctor's office together. So that way we know, oh no, you ain't scared. No, you better get up and get out, get in line, and we're all going to march up to the front of the church, and then we're all going to go back to our seats together. We got to figure out a way to all go and access health. And that's why I like some of these models where we can come to housing developments or schools or churches or workplaces, because now you're doing it as a communal activity rather than one-off individual cold and sterile waiting room with some receptionist who doesn't even want to see you or be there. And then you go sit in a room all by yourself, feeling isolated and afraid, and the doctor's going to tell you something scary. And then you got to go drive home with all that scary information in your head with a prescription. And then you got to go to the labs and the x-ray and this, that, and the other. So we see, when we break it down, why people don't utilize care. We've got to figure out a way to break that model up. And that's what we could talk about at future conversations. To your point about younger people and risk behavior, we know that Young Invincible is a part of it. Whether, that's just the riskier behavior young people engage in. I don't like to be alarmist, and I don't want to make people afraid, but I do think that viruses still pose a very serious threat. And we see that whether it's, let's say herpes virus, whether it's sexually transmitted or just people get cold sores on their mouth, but we know that laying dormant for decades and then comes back and may increase your dementia risk. I mean, those are the real risks of the herpes virus. When we look at childhood chickenpox, now we have chickenpox and the zoster vaccines, but those who had chickenpox as kids have that risk of zoster preventable now. Why would you suffer through all that agony? And we know that if it has ocular or eye involvement, can really be devastating. Zoster shingles can be extremely difficult in people. And that's another example of where decades later, a virus that you had as a child reemerges. We see this time and time again with bacterial, microbial, viral agents, where you had that ear infection, you had that strep throat, and decades later, you've got rheumatic heart disease or other things like this. So please just use those antidotes. And that's what I talk to young people about is, really balancing the known with what we don't know. I tell you what we know. I tell you what I don't know. We'll be honest with you. And based on that, I hope you make the most informed decision. For me, that also means then I want young people to have some baseline science and health literacy. Really comes down to education, because then they can take all that data and information and make the right choice for them, and not just think that they're going to make green juice and exercise and do all those things their way out of it. Those are important parts of it, and sleeping right's an important part of it, and taking care of your anxiety and depression is a very important part of it all, but those don't necessarily prevent infectious diseases or treat infectious diseases when you do get sick. And so I really do think those are the types of messages that sometimes resonate with young people, because we're up against, well, my Vitamix will fix that and I'll just go to the gym every day. Well, we know there are plenty of young, healthy examples where that did not save them. And there are plenty of people that do have long COVID, or people that did still get COVID despite all of those strategies. So I want people to do those things, but just know those aren't a replacement. And as we talked about the, chewing and walking gum at the same time, or as Dr. Walk said, there's so many things to keep on that radar. That is true. That is the harsh reality. There's a lot of it, but together it eases the load, and we can manage our diabetes while mitigating or reducing our COVID-19 risk. That is possible. And we don't need to bypass our breast cancer screening or colon cancer screening or prostate cancer screening because of those things. So we can do it all, but it is hard. And that alone is a job in and of itself. So that is a challenge. We've got to figure out how to break down those barriers, because by the time any one of us even for us, it's exhausting. I care for an aging mother who, has kidney failure and she's got all of her appointments. Even for me, I sometimes wonder, how is anybody supposed to navigate all these appointments and especially when you've got a serious chronic condition? So I hope that kind of answers where we go from there. Not worth, I talk about gambling. We are not gambling people. We don't need to blow our money at the table. We don't want to gamble with the risks of COVID. We do know vaccines work. They have very few long-term. There's really no data about long-term consequences of vaccines. What we see is that if there are issues, vast majority within the first couple of days, everything else resolves within 6 to 8 weeks. The odds are wonderfully in your favor if you go and do your part and take the public health recommendations, including getting vaccinated seriously. What we do know are the odds are not the best when you want to gamble with viruses long-term. And we don't have that 6, 7, 8 decades worth of data about how COVID one day may increase your stroke or heart disease risk or affect your kidneys or your liver or other conditions in your body. And so just want people to really keep that in mind. And I don't like the boogeyman approach or the fearful approach, because we shouldn't live in fear, but just stating the facts out there. And based on those facts and those odds, I would much rather be safe, take Paxlovid if I got positive, get the vaccines, use those recommendations. And here in LA County, as much as it's going to be aggravating, it looks like we may be wearing masks again, but that's kind of what it sometimes takes to, prevent the spread. And there's still a debate as to whether masks work or not. But I just want to say we all are using the information we have in order to do the right thing, the best thing that we can to survive. And so we just continue in public health to ask for your patience. We ask the public to bear with us, because we too are trying to figure it out as we go along and do the right thing so that people don't get hurt, don't die. And so thank you for that opportunity. Thank you for letting me address all of y'all today on this Sunday. Thank you.
And thank you for doing it so expertly. Before we go, I do want to introduce Mr. Dorsey. Mr. Dorsey has a device that he's been talking to us about for a few months. And I think given the infectiousness of these new variants, I'd like him to give us a minute of what this device is and how useful it is. And we have a relationship with his company that if people who watch our show purchase this machine. Mr. Dorsey, can you make sure?
Yes, sir.
How are you? How's Louisiana?
Very good. Hot.
So I remember Mr. Dorsey, I asked him what goes in Louisiana gumbo. He told me whatever you can catch, you put it in there. But give us a minute about the machine that you have so graciously said that you would make periodic donations to the Black Health Trust if you sold us some of these machines. What do they do?
This is the first FDA class medical device technology that sanitizes your indoor environments 24/7. I have the information in the chat box for everyone to see. Recently, the company just entered an agreement with PayPal so that the larger home units can be bought on a 4-month installment, same as cash, 6 months interest free. And then you can negotiate if you want to finance it for longer than that. That covers 2,000 square feet, your whole home. Then there's the mobile unit, which I really advise if you're going to be traveling, especially to hotel environments.
Mr. Dorsey, we can't hear you very clearly. Do you have 2 machines on?
Let's see here. Is that better?
Go ahead.
Okay. As I said, the information is in the chat box. There's a 48-minute video that describes how COVID is spread and how this machine works to eliminate it. The pricing is there for the whole home unit, 2,000 square feet, with PayPal arrangements. The mobile unit covers a hotel unit if you were traveling. And the mobile unit I wear as a necklace. I don't leave home without it. It covers about a 5-foot bubble of protection. My contact information is in there. If anyone needs any additional help, just give me a call.
Thank you so much. This has been a great day. So as we get ready to sign off, I'd like final comments by our two co-moderators. And Dr. Abraham, this is always great. You make our job so easy. You don't leave any questions to be asked of you. Dr. Walks, how you doing, my friend?
I am doing well, Dr. Maxey, and everything you continue to say about Dr. Abraham, I endorse vigorously. I wanted to, Dr. Maxey, take a minute. You and I had talked earlier about me letting folks know what I'm doing with the Black Coalition Against COVID and the Ad Council and what have you about mental health. And I wanted to make sure that we had that opportunity. So can I take a minute or two?
Yes, of course.
Okay, good. So I made a comment a few weeks ago and probably a few weeks before that about how important it is for folks who are doing well to do well together, or at least know what the other is doing, where there are opportunities to partner. That's why I love so much whenever Dr. Abraham is here and he talks about his partnering with the community and being out in the community and doing things on site. As I understand it, Minority Mental Health Awareness Month is upon us. And so the Black Coalition Against COVID, the Choose Healthy Life organization, the Ad Council, and blackdoctor.org have come together to do a town hall for the Black community. And it allows us to tap into the 2.2 million Facebook fans that blackdoctor.org has, and actually raise the profile of this mental health concern that we are so. We've talked about this for several weeks, over several weeks. We're in the middle of a mental health crisis. Everybody knows that. If you don't believe it, try to get a therapist. They're all full, they're busy. It's just a very challenging time for us. So this virtual town hall is called Let's Talk About It, Mental Health is Real. And it's in recognition of Minority Health Awareness Month. It's going to be an hour and a half, an hour and 15 minutes from on Thursday, July 28th, this coming Thursday. And you can catch it on blackdoctor.org's Facebook page. They also have a youtube.com/blackdoctor.org that folks can reach it. The content is to define mental health and the prevalence in Black and Brown communities, explain the signs, symptoms, and support with greatest emphasis on our children. Folks will be sharing real experiences and real resources to help individuals and families. And it's not going to be just a bunch of smart people talking at you. There'll be an initial panel. We have our celebrity host is David Mann. For those of you who never saw my favorite movie in the whole world, Meet the Browns, go watch it. So David Mann will be our celebrity co-host. Dr. Reed Tuckson, who many of us know, an extremely prominent African-American physician for decades and decades. I think he might be older than you, Dr. Maxey. No, he's not.
Unfortunately not. He was one of my students.
So Dr. Tuckson is pulling this together and will be moderating it. There will be also some inspiration moments, some singing and spoken word that will occur. So I just want to encourage everyone to find some time on Thursday, the 28th, this coming Thursday, from 8 p.m. to 9:15, and to find the blackdoctor.org site on YouTube or on Facebook and watch this. One of the reasons to have a David Mann and to have some other folks who are not scientists is to really, going back to what Dr. Abraham was talking about, we need to find ways to connect with our community around the things that our community connects with. So this effort is really a significant one. Years ago, I worked with the Ad Council and the White House on the National Mental Health Awareness Campaign to make mental health care parody the law of the land. And we achieved that. Now we're looking to normalize mental health. I believe that there isn't really mental health, there's just health. And so when we think about how do we address things like diabetes versus depression, we address them the same way. The doctor will come in, do some sort of assessment, you'll get some sort of medication maybe, and you'll get referred for some kind of therapy, whether it's a dietitian or somebody to work out with. But these diagnoses, we don't think about them the same as any other health diagnoses that for which we need resources and we need follow-up. And so I think that efforts like this to bring in folks like the Ad Council, the ones who invented Smokey the Bear and all these other kinds of things from way back when, and have been impacting our culture for decades and decades, and bringing in the entertainment side of it to attract people, and bringing in some content in there that is not just strictly science, but how we can connect with people around these issues. I like this kind of stuff. I think this kind of stuff works. I think it's part of this effort to really normalize what we're doing so that people are more accepting of what comes from the mental health community, what comes from the scientific community. And I can go on for another 20 hours, but I'll stop there, Dr. Maxey.
No, thank you very much, Dr. Walks. And I want to remind everybody that next week we're going to have another treat, much like today was with Dr. Abraham. Dr. Patrice Harris, the immediate past president of the American Medical Association, who's the first Black woman president of that group. In case you don't know, the National Medical Association was formed in 1895 and modeled itself after the AMA, which back in those days, they didn't allow physicians of color to join the AMA. So this young lady broke history and became the first Black female physician to be elected as president of that group. She also, Dr. Walks, is a psychiatrist. I don't know what's happening here. She's from Atlanta, Georgia.
You guys are starting to recognize that we are actually doctors and we can contribute in amazing ways. Thank you for pointing that out, Dr. Maxey.
Yeah. Anyway, she's going to join us next week, and she's going to discuss aspects of testing in our community. And so we're looking forward to that. She lives in Atlanta and has a wonderful CV. So I want everybody to consider joining us next week from the National Medical Association. I was trying to get Dr. Napier to come, but she won't go. But she'll still be here.
Virtually, I am going virtually.
You are going virtually. Okay. Well,
Dr. Maxey, can I jump in real quick for
Sure.
two things? One, there's a question in the chat whether what I was talking about is Central Time. It's Eastern Time is the time that I was giving. Eastern Daylight Time.
and what time is it?
8 to 9:15.
In the morning.
Dr. Maxey, it's PM. Nobody on the West Coast is up at 8 a.m. Eastern Time except you. Because that would be 5 a.m. for you. So no, we're not doing that to people. It is from 8 p.m. to 9:15 p.m. and that would be Eastern Daylight Time. The other question is, and I just wanted to hit this quickly. There's a question in the chat that really is looking at the fact that it's been stated this virus is airborne. Does that mean it's everywhere and difficult to avoid? And I think these are the kinds of real questions people have. Does that mean I have to hide inside my house because the virus is everywhere? No, it doesn't mean that. There's a lot of good guidance about when to put your mask on, where your mask is more effective. Do you need your mask if you're outside jogging in the park by yourself? All of those kinds of things. And I would encourage everyone to find that information and be clear about what's going on. But if you're in a small family reunion in somebody's garage and nobody's wearing a mask, yes, the virus is airborne and hard to avoid. It really depends on your circumstances, but it's a very good question to try to clarify what kind of risk you're going to be involved with based on where you're going to be.
Now, let me ask, Dr. Abraham, can you give us a 60-second answer on that question?
Yeah, it's definitely spreading, very rapidly now, and basically it's very hard to avoid. I think that's why we're wondering, do we need to go back to distancing or masks? Because you're right. I mean, as Dr. Walks mentioned, if you're in a close space with someone beyond 15 minutes, if they have it, you're probably going to get it, which is why the best protections are having your vaccines and making sure that if you do test positive, you go and get Paxlovid and you do get tested. If you find out you've been exposed for that long, or if you're having symptoms, not getting tested means you don't know whether you have it. So those are all very important parts of the strategy. We do think it is spread by respiratory droplets. It is aerosolized. We can breathe it in. It is all around us, but that's true of the common cold. That happens with the flu. This really is the reality of learning to live smarter with COVID and COVID going from pandemic to endemic. So yes, it's all around us, but we cannot let it control us or make us live in fear, because you still need to do all those things you need to do that we've been putting off for years, because time is ticking and time is really the only thing we can never reclaim or buy any more of. So I don't want anyone not living their life to the fullest because of fear of COVID.
Dr. Neighbor-Stevens, any final thoughts?
Well, I would end as I frequently do and say, use your common sense and don't forget to wear your mask when you're going to be around people, because you don't know what they have.
Well, very good. And I thank everybody. Dr. Abram, this has just been wonderful. And we'd like you to come back. What the old mayor of Chicago used to say, vote early and vote often. We want you to come early and come often to be a guest on the Black Health Trust. You're certainly welcome. We ask everybody to join us again next week. And I especially want to thank our technical person, Mr. Simon Cooper, who has tirelessly helped us put this on every week from Florida. And last week he did it from Cincinnati, Ohio. So thank you, Simon, for that. And periodically we have a good flyer, and I'd like to thank Skylar for working with us on that. So everybody have a great day. Thank you very much.
Good day, everyone.
Bye.